Hi, welcome to the podcast for the second midterm for Econ 403. So, in this podcast, I'm going to go through the multiple choice questions and discuss the answers to them. So, I'm going to split this up into four parts that correspond to the four sections on the exam: the hospital market, the market for insurance, adverse selection, and moral hazard. So, let's go ahead and get started on the hospital market. Question one: which of the following best describes the Hill-Burton Act of 1946? So, the answer there is A, provided funds for building hospitals in underserved areas. Really, the key thing to remember about this act was that as new technology made hospitals more effective at treating diseases, there was an increased recognition of the social benefit for these hospitals. So hospitals used to be, funded by charities and things like that, and so the government recognized that this wasn't a sufficient model of putting hospitals in enough places where the people needed to get them, and so there was a recognition that there should be some federal funding for hospitals, especially in areas that didn't have any already. Question two: which of the following reasons are for which of the following reasons are average hospital stays in Japan longer than those in the United States? And so the main reason here is going to be B. Japanese hospitals are more likely to be compensated on a fee-for-service basis than a diagnosis-related groups basis. So a fee-for-service, basically, the hospital gets compensated for everything that it does. And generally, it gets compensated above marginal cost, so there's an incentive for the hospital to do more things to keep you there longer. The DRG basis payment compensation is where essentially you get diagnosed with something when you go to the hospital, and then the hospital is paid by the insurance company a flat rate. So this was sort of popularized by Medicare in the U.S. and it's spread through a number of different countries. And so let's say you go in and you're diagnosed with appendicitis, and the hospital's compensated, let's say, $20,000 for that. Now, it doesn't matter if you have complications from that surgery and you have to stay longer. The hospital doesn't get any more money for it. And so the incentive then for the hospital is to get you in and get you out as quickly as they can. And so fee for service tends to result in longer hospital stays than DRG is there. Now, that's not to say that hospital stays in Japan have continued to increase over time. They've actually gone down over time, just at a slower rate than in the US. And the reason why they've gone down all over the world is that there's better technology, such as laparoscopic surgery, which has reduced the amount of time that you need to spend in the hospital. Essentially, there's shorter recovery time from surgery when it's just a very small incision versus cutting you all up. And there's an increased usage of outpatient facilities. But holding that constant, the increased technology, then a country which primarily uses FFS is going to, on average, have more lengthy hospital stays than a country that uses DRG. All right, number three, which of the following models of hospital physician interaction with the quality of care, assuming you get treated in the first place, be the lowest? And so here we're expecting that when physicians are directly employed by hospitals, this is going to result in the lowest quality of care. The reason for that essentially is that when physicians are employed by hospitals, is the hospital administrators that have more bargaining power in terms of what range of services are going to be done. So if you think about the physician workbench model, the physician is utilizing the hospital service. The physician sees a patient in the hospital and orders a whole bunch of tests, orders a whole bunch of procedures. The hospital administrator is negotiating with them, but the administrator doesn't know as much as the physician, and so they generally sort of adhere to whatever the physician's saying. Now, if the physician's employed directly with the hospital, the administrator is going to have more say over what gets done, and the administrator cares more about the hospital's bottom line than necessarily the absolute best possible health of their patients. And then doctor-owned hospitals, here you kind of have sort of an average in between physicians' workbench and physicians employed by hospitals, because the doctors are still making decisions, but they also own the hospital. So that's going to factor in there as well. Okay, question four. Which of the following is true about the volume outcome relationship? And so this is the observed relationship that hospitals that treat more cases for a particular procedure tend to have better outcomes for that procedure. And it turns out that experience matters more for hospitals than it does for physicians, but the best possible outcome is when you get a very experienced hospital with a very experienced physician. Okay, five. All of the following are reasons why the hospital industry is best characterized as a differentiated product oligopoly, except. And so, a differentiated product oligopoly is going to be a model of competition that is less competitive, certainly, than perfect competition. It's not quite as uncompetitive as a monopoly, but certainly there's not perfect competition there. And so some of the reasons why there's not perfect competition are, for example, that there's high fixed cost of building a hospital. So it's not like there's easy market entry and exit. If a hospital is making profits, you can't just build a hospital next door. That's really expensive to do so. Furthermore, you're going to face government regulations. You need to basically show that there's a certificate of need to build a new hospital. These are difficult things to get. And so, again, this limits the ease of entry and exit. And certainly, hospital services are not perfect substitutes, they're imperfect substitutes. Some hospitals are better at doing some things than others. In emergency situations, distance is really the only consideration that oftentimes matters. And so it's not like you're able to shop around for the cheapest hospital if you're having a heart attack, for example. And so A through C are, in fact, reasons why the hospital market is a differentiated product oligopoly. Only D is essentially just not a real thing. There are not any government regulations that mandate there's only one hospital in each metropolitan area. Um, just think of San Diego. We're a metropolitan area, and we have lots more than one hospital. We certainly don't have as many hospitals as perhaps we would in a perfectly competitive environment, but there's definitely more than one. All right. Question 6 asks you to compute the Herfindahl-Hirschman index for hospitals in San Diego. And so to compute this index, you basically square the market shares of each individual hospital, then you add those squared market shares. So here you take 0.3 squared plus 0.4 squared plus 0.3 squared. So that's 0.09 plus 0.16 plus 0.09, and that should give you 0.34. And so this is just a measure of how competitive a particular market is. And so to give you an example, really anything over like 0.25 is considered to be not a lot of competition, a very concentrated market. And so if you have 0.34, which is actually pretty standard for hospitals in the data, you have a real lack of competition. So question 7 asks you, on the basis of the data in table 2, which of the following scenarios is most likely, assuming there's no quality competition between hospitals. And so when you look at this, you can see that the Chula Vista market is more concentrated, i.e. there's less competition than the San Diego market. We can see that because Sharp has 80% of the market in Chula Vista, whereas the other hospitals in San Diego have a little bit larger market share. So we can see that because there's less competition in Chula Vista and San Diego, in fact, we'd expect that there would be a higher price charge in Chula Vista because there's less competition. So A is not right. The quantity of healthcare provided in Chula Vista, since there's less competition, is actually going to be smaller than it is in San Diego. And in D, the FTC would label actually both markets as concentrated because both of them have an HHI index above 0.25. And so it's really B, the Chula Vista hospital market is going to experience a greater welfare loss than the San Diego market. Now, I say this with a little bit of a caveat because we did talk about later on in this section that yes, the classic model of competition would suggest that less competition leads to a greater welfare loss, but there are some reasons to believe that less competition might actually be good when we're talking about hospitals. An individual hospital that's not facing the most competition is, for example, going to get more experience, and that's going to perhaps increase the volume outcome relationship. Furthermore, there might be less of a possibility of a race to the bottom if these hospitals are competing on the basis of quality as opposed to price. And so that's why I gave you a little caveat here, assuming that there's no quality competition between hospitals. Okay, question 8. For which of the following reasons would we observe price competition between hospitals? And so the idea here is that we can't say that hospitals don't compete at all on price. There is still a little bit of price competition between hospitals. And the only one of these reasons why we observe that amongst the 4 that are listed here is that managed care organizations, or as you might know them, HMOs, restrict enrollees to specific approved hospitals. So basically, if a hospital is too expensive, they run the risk of being dropped from the MCO's list of approved hospitals. And so hospitals there are at least still a little bit constrained in terms of how much they can charge. A, B, and C are actually reasons why they would not compete on the basis of price. So, for example, Medicare paid a fixed amount. So, given that, it doesn't really matter what price the hospitals are charging. Medicare is compensating the same amount. B, search costs are high. Price information can be difficult to obtain. Again, that's something that we would require for price competition to be there, that people are able to compare prices. And so, if it's hard to find how much one hospital costs versus another, then there's not going to be as much price competition. And then certainly, as we talked about earlier, in emergencies, location really is the primary consideration. So again, if you're having a heart attack, the ambulance is rushing you to the hospital where minutes matter. You're not going to go 20 minutes out of the way to go to the cheaper hospital. You're going to go to the closest one. Question 9. For which of the following reasons would the medical arms race be good for society? So the medical arms race is basically the quality competition between hospitals where they are competing, for example, to get the latest and greatest technology. They keep on buying equipment. And we might end up, if it's bad, we might end up with, for example, redundant fixed costs, a lack of specialization. We might get, more competition that's happening. They're replicating services. In each hospital, ended up seeing fewer patients for a particular procedure. It certainly could potentially magnify physician-induced demand, since especially if, in the case of a doctor-owned hospital, the hospital buys a new, let's say, MRI machine, then the doctors that also own the hospital are more likely to order an MRI test when it might not necessarily be required. And so, really, the only reason why the medical arms race might be good for society is that it does induce hospitals to seek out the latest technology, and this technology could potentially improve patient outcomes. Now, you got to balance this against the fact that when all these hospitals are spending so much on this technology, of course, the cost of healthcare is going to go up. And so, even though patient outcomes are going to go up, the cost of healthcare goes up. And so, we need to find that perfect balance between cost and outcomes. Question 10. Which of the following patients is likely to face the lowest hospital bill? And so, when we think about the price charged at a hospital, it's a function really of two things. It's a function of the kind of insurance that you have and the sort of the quality, the reputation, the rating of that hospital. So, for example, Abdullah here is on Medicare. And so Medicare covers a lot of people. So Medicare has really strong bargaining position when it comes to hospitals. Medicare is able to basically go to the hospital and say, we're going to give you a lower payment than, for example, a private insurance or certainly somebody who's uninsured. And because the hospital doesn't want to lose all of its Medicare patients, it's much more likely to give Medicare that price break. Now, when we think about the hospital side, really star hospitals, really famous hospitals, are able to charge a higher price. And so if you just go to, some random hospital in the middle of nowhere, they're not going to be able to charge as much for a procedure, for example, as the Mayo Clinic, a really, probably the best hospital in the country. And so, here an independent and moderately rated hospital certainly is not going to be able to extract more price, especially not out of Medicare. So Abdullah here is going to be the one that gets probably the lowest hospital bill. Bianca also on Medicare, but because she's going to a highly rated hospital, she's probably going to face a higher price. Chun, uninsured, that basically means that he has no bargaining power, right? So he's not, collectivizing his bargaining with a whole bunch of other people that are on the same insurance. Chun's probably going to pay a really high price, even at this independent, mildly rated hospital. And then Daniel, private insurance, that's sort of the second highest price you would pay after uninsured. And a hospital that's a member of a hospital system. So again, this all goes back to bargaining power. This isn't one hospital, but this is a number of different hospitals that collude basically to set the same price. And so they're able also to charge a higher price. And so Abdullah is definitely going to pay the lowest price. Bianca probably would pay the second lowest price, followed by Daniel, followed by Chun. 11. Which of the following is not true about uncompensated care? And so uncompensated care basically is you go to the hospital and they treat you. They're not going to not treat you if you don't have any money. But then let's say you can't pay your bill. And so basically there's three ways that the hospital is going to pay for the services that they rendered. One, it could come out of their profits. Two, there are government subsidies, especially to hospitals that have a lot of uncompensated care. And then C, they might basically pass that cost onto other customers, especially the privately insured. And so they're going to charge higher rates to the privately insured to compensate for that uncompensated care. And so, given that they clearly somebody is paying for this, and sometimes and oftentimes it's not just the hospital itself. D here is going to be not true about uncompensated care. There are more people hurt by uncompensated care than just the hospitals and their shareholders.